I'm Dr. Julia Wood. I'm a psychiatrist in Knoxville, Tennessee, and I'm going to talk to you about perinatal mood and anxiety disorders with a focus on the postpartum period. Perinatal mood and anxiety disorders are common. The first 3 months postpartum is the highest risk time in a woman's life for developing a mood or anxiety disorder. Postpartum depression is the most common of these disorders, occurring in up to 1 in 5 women. This is often characterized by high levels of anxiety and difficulty sleeping because mom cannot relax. Anxiety or panic disorder can also occur. Obsessive compulsive disorder is characterized by obsessive images or worries and can also be accompanied by compulsive behaviors that mom may do to get worries out of her head. At times, these obsessive thoughts or images can be very distressing to mother. They can involve worries about harming baby. Moms may be reluctant to talk to providers for fear they may be labeled as crazy. It's important to note that women with obsessive compulsive disorder are not at risk of harming their babies, even though they have these distressing thoughts. Post-traumatic stress disorder can involve intrusive memories of a traumatic or frightening childbirth experience. For women with a history of bipolar disorder, depressive episodes are very common in the postpartum period. And postpartum psychosis is often the manic form of bipolar disorder that can occur postpartum. Women may have hallucinations, delusions, confusion, disorientation, and they may not sleep. This is a medical emergency and needs to be urgently evaluated by a mental health professional. Now that we've talked about what the disorders can be, we're going to talk about some common risk factors. Depression or anxiety during pregnancy. This is the number one risk factor for developing a perinatal mood or anxiety disorder, and therefore we should be aggressively screening and treating women during pregnancy. A previous episode of postpartum depression, a lifetime episode of depression, anxiety, bipolar disorder, or substance use disorder. Oftentimes, women who are taking medication for a psychiatric disorder may stop medication either in anticipation of pregnancy or when they learn that they become pregnant, thus putting them at increased risk. A recent stressful life event, such as a death in the family or financial stress, marital problems, insufficient social support, or a history of trauma. Knowing some of the common risk factors, here are some tools for prevention. We should provide women with education on what to expect postpartum. This includes physical symptoms, expectations around breastfeeding, as well as emotional symptoms. It is common in the postpartum period for women to have what is often called the baby blues, increased anxiety, irritability, weepiness. This peaks around 5 days and resolves around 2 weeks. In between times of feeling anxious or weepy, women will feel normal, be able to enjoy time with their babies. Women should be encouraged to create a postpartum plan and contract. This should be done in conjunction with her support network. This should focus on questions such as who will feed the baby, how are we going to ensure that mom gets enough sleep, and what symptoms or signs should we be looking out for to know that mom may need more support, and who do we contact to get her that support. We should be helping mom enlist her support network and encouraging her to focus on self-care, nutrition, exercise, sleep, time for self, and supports. Sometimes mom's postpartum depression is not preventable. Here are some treatment options. Sleep is important in treating postpartum mood and anxiety disorders. Mom should be encouraged to get a 4-hour chunk of uninterrupted sleep. In order to do this, she may need to help figure out who will do overnight feedings so that she can get some rest, or who can come relieve her during the daytime. We should be encouraging mom to enlist her network of social supports and offer other resources, such as new mothers groups in the area or groups focused on postpartum depression. Psychotherapy has been studied in treating postpartum depression. Both cognitive behavioral therapy and interpersonal therapy have evidence. I would also encourage you to familiarize yourself with providers in your area who have experience in treating this group of women. In more moderate to severe illness, we may need to use medication. Most antidepressants are compatible with breastfeeding, and women should not stop breastfeeding merely because they start medication. Sertraline is often a good choice for medication-naive women or women who've responded to this medication in the past, but we should give consideration to what a woman has taken previously. If a woman has previously done well on fluoxetine or venlafaxine, I would not hesitate to start these over sertraline simply because of the breastfeeding data. We should also not be underdosing medication. There is no evidence that lower doses of medication are preferable versus higher doses in terms of risk to baby. I often start women on a low dose of medication, such as 25 milligrams of sertraline for the first few days, encourage her to increase it to 50 milligrams if she is tolerating it well without significant nausea after about 4 days, and then I like to check back in with her at about 2 weeks and increase the medication further if needed. There are a number of resources available for providers and patients to guide them through things such as prescribing medication during pregnancy or breastfeeding, as well as support groups or additional therapies for patients. Today, we've talked about perinatal mood and anxiety disorders in the postpartum period. We've talked about prevention and treatment options. Here are some of the key takeaways. Depression or anxiety during pregnancy is the #1 risk factor for a postpartum episode of illness. We need to identify and educate women at risk for postpartum illness, and medication risks should always be weighed against the risks of untreated illness. I hope you found this information helpful.
Hello, I'm Dr. Jessica Young. I'm an associate professor at Vanderbilt University Medical Center and an obstetrician gynecologist who specializes in addiction medicine. Today, I'm going to talk to you about the 4th trimester and relapse prevention for the woman with substance use disorder. The objectives for this presentation are to introduce the concept of the 4th trimester of pregnancy. We will understand risk factors for relapse and identify relapse prevention strategies. We will identify relapse prevention resources and discuss 4th trimester paradigm for women with substance use disorder. So what is the 4th trimester? In obstetrics, we are used to thinking about pregnancy as having 3 trimesters. The concept of a 4th trimester is a new idea for obstetrician gynecologists and other OB providers. The idea of a 4th trimester is a new paradigm for postpartum care. Postpartum care is an ongoing process. It should be considered holistic. Contact with an OB provider is recommended within 3 weeks of delivery. A comprehensive visit is then scheduled within 12 weeks of delivery. This is a time where chronic health conditions are addressed and treatment plans are made for other chronic health conditions, both mental and physical. The American College of Obstetricians and Gynecologists provides a proposed paradigm shift for postpartum visits. Instead of a traditional period of rest and recuperation from birth from 0 to 6 weeks, followed by a 6-week postpartum visit, the 4th trimester involves early contact with all women within the first 3 weeks, a blood pressure check within 3 to 10 days, and an in-person follow-up for those women who are high risk in 1 to 3 weeks. A comprehensive postpartum visit and transition to well woman care is recommended in 4 to 12 weeks, with the timing individualized and woman-centered. During this 12-week time, the primary maternal care provider assumes responsibility for the woman's care through the entire 12 weeks. For women with substance use disorder, the postpartum period can be a time when they are at a higher risk for relapse. Maternal mortality data from the state of Tennessee shows us that substance use disorder is a significant contributing factor for all pregnancy-associated deaths. This risk increases after delivery up to the first year. Factors that contribute to being at higher risk for relapse include isolation, physical stress, mental stress, lack of sleep, separation from infant, whether that be from Child Protective Services or in a medical setting, mood disorders, lack of continued medical care or addiction treatment, and in general, the removal of the protective factor of pregnancy. Given that the postpartum period can be a stressful time, what are things that we can do to help a woman prevent relapse? Scheduling a woman for short interval follow-up, making sure there are warm handoffs between providers, linking a woman to care, including resource linkage, plan of safe care for both mom and baby, screening and treatment of mental health disorders, making sure that we have developed an individualized treatment plan, and incorporating motivational interviewing and goal setting. The following are examples of resources that it may be helpful to link patients to: home health visitation services, peer support, addiction medicine specialist, referral to treatment, behavioral health, lactation support, and a pediatrician with experience in care of the opioid-exposed newborn. This is what the 4th trimester paradigm for a woman with substance use disorder would look like. We have our patient referred to home health, lactation, peer support, case management services, and any other additional resources that are available at the time of delivery. She has an appointment with her addiction medicine specialist within 1 to 2 weeks after delivery, as well as contact with her obstetric provider within the first 3 weeks. She is then scheduled for a comprehensive postpartum visit and transition to well woman care within the first 4 to 12 weeks of delivery. For women with substance use disorder, the postpartum period provides some unique challenges. It is a time when we can harness additional resources to help support women in these challenging circumstances. The paradigm of the 4th trimester expands care for postpartum women. Women with substance use disorder can benefit from increased support during the 4th trimester and the first year after delivery. We hope that you found this presentation helpful. For more information on substance use disorder treatment, the 4th trimester, and relapse prevention, we've provided the following resources.